in myocardial infarction trials with this decrease in the curve for mortality. And we have said that now this curve is plateauing, and of course one way to flatten this curve further is really to look for something different, because of course with what we have we didn't zero these events. So let's start with the drugs. Well, we have seen something about the timing of treatment in myocardial infarction, symptoms onset, and then there is a 2-6 hours delay before the first medical contact and diagnosis. Then there is less than 1 hour for the arrival at the hospital, and then we start the standard of care, revascularization and therapies. And in terms of platelets, this makes a lot of difference, because during the time between the symptoms onset and first medical contact and diagnosis, we have the so-called period of vulnerability, where the platelets dominated the thrombus composition within the first 3 hours. And then, of course, there is the coagulation cascade, and fibrin takes the stage, and we start to have a mixed thrombus within 3 to 6 hours. Then, when the patient is already at the hospital, we have a fibrin-rich thrombus more than 6 hours, particularly, of course, in non-ST elevation myocardial infarction, but of course, it depends on when the patient will ask for help. So the risk is that if the patient arrives late, or the patient asks for help late, we will have a thrombus that we cannot dissolve simply with antiplatelet medications, because fibrin is the dominating force here. So zalunfiban is a glycoprotein 2B3A inhibitor. It's given subcutaneously. The onset of action is 15 minutes. The offset is 4 hours. It has been designed to be injected by medical first responders. So in other words, to be given in the ambulance to save time and avoid that the thrombus is still stabilized by fibrin. This drug is now tested in the Celebrate trial, which is a multi-center, double-blind, randomized study that will give results, hopefully, by the end of 2024. 2,499 subjects, STEMI, undergoing primary PCI, and you see that the endpoint is a composite of 7 outcomes, and the comparison is versus placebo. Another interesting drug for the future is selatogrel. It's a P2Y12 inhibitor like clopidogrel, prasugrel, ticagrelor, but it is subcutaneous. And again, the onset is very fast, 15 minutes. The offset is also quite fast, 24 hours. And in this case, it's a pen given to the patient, so not even to those who are in the ambulance. So the idea is that this drug could be suitable for self-administration, which is very, very tricky, of course, as you may imagine. But this is tested in the SOS-MI trial, which is ongoing. I think even in terms of design, this is a very challenging study, because it will start with 14,000 subjects with MI at risk of recurrence. So they have the first event, and of course we want to avoid the second and the third. They will be given the pen with placebo or a selatogrel, and then of course at one point in time, we don't know when, they will self-inject because they have chest pain and they feel it's like the first myocardial infarction. So the estimation is that 5,000 subjects will do that, and 1,000 subjects will self-inject and actually have a myocardial infarction. So in the end, there will be a comparison in 1,000 subjects out of 14,000. Very challenging design and also analysis. Selatogrel versus placebo, and you see the primary outcome. So we will see how this thing evolve. Of course, there is a scrutiny of safety for this kind of trial. Let's discuss now coagulation rather than platelets, and we discuss essentially thrombosis. As you know, this is the coagulation cascade in the classical depiction. We have the tissue factor pathway, which was called the extrinsic pathway, and the contact pathway, which is the intrinsic pathway. So when there is development and growth of pathological thrombus, there is a substantial contribution of the contact pathway, and particularly of the factor 11 and factor 11A. You see that factor 11A activates factor 9, and it is activated by factor 12A, which is essentially activated by metal, foreign bodies, etc. But the main activator of factor 11 is thrombin. So essentially, there is a loop here that amplifies and progresses the growth of the thrombus, which is substantial when there is, of course, plaque disruption, to make an example. This pathway is substantial when there is thrombus, but is trivial when it comes to hemostasis. So essentially, in the repair healing of wounds, etc., it's not activated. So the idea is that if you tackle factor 11, you may uncouple the contact pathway and the tissue factor pathway. In other words, you reduce the pathological thrombosis and you do not interfere with normal hemostasis. So in this way, you could decrease the thrombus and hopefully reduce the risk of bleeding, but this has to be shown and tested. Milvexian is a factor 11 inhibitor. It's an oral drug. The onset of action is 2 to 4 hours. The half-life is 11 to 18 hours. So this means that this drug can be given orally daily. You see that this drug has been tested already in 2 settings, in the venous thromboembolism, total knee replacement, and also in the arterial thromboembolism with the reduction of stroke. And now it's tested in a large study, which is called a Librexia ACS. This is a multi-center, double-blind, randomized study of 16,000 subjects with ACS and enrichment criteria on antiplatelet therapy. These patients will be randomized to milvexian or placebo, and they will be tested for a composite endpoint at 3 years of cardiovascular mortality, myocardial infarction, and ischemic stroke. Results are expected in fall 2026. Let's discuss now devices. What I think is interesting here is to see how the story of Impella evolves after danger shock, as we have heard. So this is the percutaneous microaxial flow pump, which increases blood flow and improves the organ perfusion, and also now has shown to decrease death in patients with acute myocardial infarction and cardiogenic shock. The RECOVER 4 trial is the next in line. Results expected in December 2027. Multi-center, randomized, open label, of course, 560 subjects with STEMI cardiogenic shock. They will be randomized to, and are randomized to, Impella prior to PCI versus standard of care plus or minus intra-aortic balloon pump. The primary endpoint is mortality at 30 days. You don't need too many patients in these trials where the mortality, unfortunately, is very high. The other interesting part of the story is STEMI DTU. This is another multi-center randomized trial of 668 subjects with acute anterior STEMI undergoing primary PCI without having necessarily cardiogenic shock. And again, here it's Impella prior to PCI. Can you think of course, how much it takes to put an Impella in a patient who has, of course, ischemia ongoing? So this is one of the interesting parts of this study, whether this is something that creates an advantage rather than a disadvantage. Versus standard of care, the primary endpoint at 3 to 5 days will be infarct size normalized to the left ventricular mass. Another interesting technology, particularly here in the US, is Tirox SSO2. This is supersaturated oxygen therapy. So essentially, you give a one-time 60-minute infusion of super-oxygenated blood delivered via a catheter to the left main coronary artery. Of course, in STEMI, you may wonder whether spending 60 minutes, of course, after the procedure, it's worthy, but essentially, there are evidences in the literature that this practice reduces microvascular obstruction and also the infarct size, and increases the ejection fraction. So it's worthy to avoid the consequences of STEMI, and particularly heart failure. They have recently launched this registry, which is called S-Score, which is multi-center and also non-randomized, but propensity match and prospective. The results are expected by March 2027. They are looking at 1,000 subjects with acute anterior STEMI and successful primary PCI who will be treated with supersaturated oxygen therapy or control. So they will look in matched patients whether this is something that works on a primary endpoint that includes many heart failure outcomes, as you can imagine. And in terms of strategies, finally, I would like to mention that, of course, one of the strategies we have to consider is complete revascularization in multivessel disease with MI. 7 trials, 6 positive. The final one, full revasc presented at ACC, was neutral, but overall, I would say that there is sufficient evidence to say that we should complete revascularization in patients with multivessel disease in the context of MI. But there are 2 remaining questions that we need to look at in the future. First of all, when this complete revascularization should occur. There are 2 trials that have been mentioned today, BioVasc, Multistas MI, that say essentially that immediate is better than stage. And there are 2 future studies that are currently recruiting future, immediate versus stage, and stage, which is comparing stage in hospital versus stage out of hospital. And in terms of how to select a non-culprit lesion to be treated for complete revascularization. We have a mixed evidence, and perhaps not so helpful, because cross-MI was very small, and this similarity essentially reflects a lack of power between stress echo and angiography. And we have two trials of FFR versus angio, one positive, the other one is neutral, so essentially the jury is still out. And the complete 2 is the trial that probably will give the answer. 5,100 subjects with MI, multivessel disease, the PCI, the infra-related artery. They are randomized to a physiology guidance versus angiography guidance, and the primary endpoint is hard. The results are 2 years, expected by 2028. I would like to rapidly mention also favor 5 MI from China, because this is something that is comparing micro QFR and radial wall strain, very interesting also for the guidance of complete revascularization versus the traditional approach with angiography plus physiology. And also 2 other trials that are comparing IVUS versus FFR. This is frame MI 2, and they are doing also frame MI 3, OCT guided PCI versus angiography guided PCI. Very small numbers, as you can see, so of course it's difficult to think that this will give a definite answer to these questions, but it's important for completeness to report that these are ongoing. Final point, aspirin-free strategies after PCI. I think this is an important development, and this is the evolutionary journal of the trials that have so far eroded the duration of DAPT over time, but the next step is to maybe eliminate aspirin at all. And there is one trial that is ongoing in STEMI, premium trial, so prasugrel monotherapy since day 0, essentially, versus prasugrel plus aspirin in more than 2,000 subjects with STEMI. I would like also to mention that there is another study ongoing, which is compare STEMI 1 after 1 DAPT, 1 month of DAPT with prasugrel and aspirin. Aspirin will be abandoned. So this is a setting where you can imagine this is particularly setting, so it's important to replicate the data already shown by many trials in ACS, in STEMI specifically, which was a population understudied somehow. I stop here. Thank you very much for your attention.